Hello and welcome to Canvas, the Niger-Delta Roundtable, where I discuss the future of this region blessed humongously with hydrocarbon resources. Every week, we give some time to reflecting on topics relevant to the development of the Niger-Delta and her people. This episode is no different, as I'm here once again to focus on how to take this region to a more promising future. And the podcast is sponsored by the operator of the NNPC, Renaissance, the Total Energies Active Joint Venture, the Renaissance Africa Energy Company Limited, headquartered here in Port Harcourt. Thank you for joining. I'm Adedayo Ilushakin. Our topic for this episode: when the immune system threatens immunity. And today, in commemoration of World Lupus Day, we're diving into a topic that affects millions of people worldwide: lupus. World Lupus Day, observed annually on May 10, aims to raise awareness about this often misunderstood condition, support those affected by it, and promote further research into its causes and treatments. Lupus is a chronic autoimmune disease where the body's immune system becomes hyperactive and attacks normal, healthy tissue. Now, this can lead to inflammation, swelling, and damage to various parts of the body, including the skin, joints, kidneys, heart, and lungs. In this episode, we'll be discussing how lupus disrupts the body's natural defense mechanisms, challenges faced by those living with the condition, and the ongoing efforts to improve diagnosis, treatment, and quality of life for lupus patients. Again, today the topic on Canvas is when the immune system threatens immunity. My guest is Dr. Tralagba Uchechukwu. Dr. Tralagba Uchechukwu is a consultant physician and rheumatologist at the University of Port Harcourt Teaching Hospital here in Rivers State. She is a fellow of the West African College of Physicians and is awaiting induction as a member of the Royal College of Physicians. Dr. Tralagba, hello, welcome to Canvas, the Niger-Delta Roundtable.
Thank you, Dayo. Nice to be here.
It's great to have you. And congratulations in order as you await your induction.
Yes, thank you very much.
All right. I wish you the very best with that.
Thank you.
Let's start from a broader concept. I know that what inspired this conversation, this recording, is lupus. If you're watching this, we're actually recording this on May 10. You will get to watch this afterwards. So it is World Lupus Day today.
Yes, it
right
is.
now. But lupus is a part of a broader range of diseases referred to as autoimmune diseases. So let's start from that. And correct me if I'm wrong, by the way.
Okay.
What are autoimmune diseases?
Okay. Just like you mentioned during the introduction, auto would mean self. That's why we have autobiography, automobile, something that is self-driven. Okay. Now, autoimmune diseases, I'll start with talking about the immune cells. They're like the soldiers of the body. They're supposed to fight infection. They're supposed to recognize what is foreign to the body. That's the reason why if someone gets a kidney from another person, that's what says, oh, this is not part of us. We're going to attack it. Now, what happens in autoimmune diseases is that these immune cells, due to a combination of factors, things that have gone wrong, instead of just targeting infections and foreign bodies, they start to attack the body itself. Okay, and now it could be a single organ being attacked. So we call that single organ autoimmune disease, where it could be the thyroid, it could be the skin, it could be the pancreas, you understand? Then in some situations, instead of just targeting one organ, it could be systemic, which lupus happens to be the prototype of systemic autoimmune disorders. So when we talk autoimmune disorders, it's just a situation where immune cells are mistakenly attacking healthy tissues belonging to the body. And then this attack now causes inflammation that is self-perpetuating. It just keeps on going on because there's always something in the body for those abnormal immune cells to attack.
So would it be right for me to say that autoimmune disease or diseases are the body's cells acting in an abnormal way? Would that be a correct statement?
Okay. They are the immune cells
Yes.
They are acting in an abnormal way, and then they are also hyper responsive.
Which is abnormal.
It's still abnormal, yes. So most times I just like to say the body is at war with itself.
Okay.
That's what happens.
Now, there's a reason I made that statement. I'm actually driving somewhere.
Okay.
And with cancer as well, what is said, or with cancers, what you hear is, what I've heard is also the body cells also acting in an abnormal way. Now, if with autoimmune diseases, the body cells, in this case, immune cells, are acting abnormally, hyperactive and all of that. And with cancers, I also hear, now I'm not the expert, so you are. No. I also hear that it's the body cells acting in an abnormal way also. Okay. So how then autoimmune disease is different from cancers? Okay, so for cancers, one, it's not usually immune cells. It could be any cells in the body. And then in cancers, they are proliferating abnormally. There's an increase in number, increase in size in cancer, and they're not responding to what would usually tell a part of the body, please stop growing. So it's an abnormality both in function and in numbers. Whereas in autoimmune diseases, specifically, it's the immune cells that are abnormal. And then the abnormality is not necessarily in numbers. It's not like they are proliferating a lot. It's abnormality in function. They are unable to recognize self. So when they are attacking, instead of limiting their attack to infections and foreign bodies, they are now attacking both self and then what they should normally attack. So is that a bit clearer? So in cancers, it's not just immune cells, and then there's an increase in the number, proliferation, and then also increase in size. And so that's why we call them growth tumors. Okay. So what is it that caused these immune cells to suddenly lose their minds and start attacking their immediate environment? Okay. Before in medical texts, they would just say idiopathic, unknown. Nobody knows. But then with research and involvement in science, evolution in science, we've been able to recognize that some things are common to the individuals that have this. A lot of factors come into play. So it's an interplay between different factors. The first is a genetic predisposition. That means it tends to run in families. But it's unlike the diseases that have specific genetic pattern where they say, okay, if your father has it, then there's a 50% or 25% chance of the child having it. So what we know is that there are some genes that have been involved, but it's not directly inherited. Then another factor is now, so if there's a genetic predisposition, not everybody with the genetic predisposition would come down with an autoimmune disorder. So that now brings in the external factors. The external factors are things like infections, not specific infection. It could be a viral or a bacterial infection in an individual that is already genetically predisposed. And then also, sometimes it could just be psychosocial stress. And then another thing is hormones. If you notice, autoimmune disorders are commoner in females of reproductive age group. And one thing that is common in this subpopulation is the hormone estrogen. So it's also been found out that the hormone estrogen has a role to play. So when all these factors come in, that's when the immune cells now start to act abnormally. So it's not one thing. It's a combination of different things in a genetically predisposed individual. So the disease, once again, is in plural, autoimmune diseases. That implies or suggests to me that there's more than one autoimmune disease. Yes. How many are there? The list is quite long. I'd spend hours if I had to start listing all of them. But then some are rare, some are common. So I'd maybe talk about the ones that are common. So we have systemic lupus erythematosus. That's the one that is lupus for short. Let's note, it's like a tongue twister almost. Then we then we have the ones like rheumatoid arthritis, where the immune cells are targeting synovial joints. Then we also have the ones where it's the muscles that are being attacked, and then that's the inflammatory myopathies. And then we also have another one that has been making some waves on the media recently. That's systemic sclerosis, scleroderma, where the immune cells attack basically both the skin and the internal organ, turning normal skin tissue and internal organ tissue into fibrous tissue. That's systemic sclerosis. And there's also another one that attacks the
glands that are responsible for making secretions in the body, like the salivary glands, the tear glands, the sweat glands, basically dry them off. That's called jugular. So it's a long list, but these ones that I've mentioned are the common autoimmune rheumatic disorders. Then sometimes it could also have an overlap where an individual has a combination of more than one autoimmune disorder, because having one puts you at risk of having another one.
Oh,
Yes.
okay. All right. Now, with that background or that foundation properly laid, thank you for that.
Okay.
Let's delve into the
Lupus.
focus of our conversation for this episode, which is lupus. So, what is lupus?
Okay. So lupus, I like to always mention the full name because some people will be saying SLE. So that's systemic lupus erythematosus. It's the prototypical autoimmune disorder where you have one, autoimmunity that is systemic, which means it's not specific to an organ, where you have abnormal immune cells that are directed against self that could attack the skin, the joints, the kidneys, the brain, the muscles, basically all parts of the body, and sets up persistent inflammation, which, if not controlled properly and detected early, could lead to sometimes irreversible damage of the organs that have been affected. That's also part of why we are doing this talk, so that we can detect it early before it causes long-term damage.
So, with lupus, the immune system attacks any part of the body.
Yes, healthy tissues in virtually all parts of the body. But then there are maybe when we talk about the symptoms, there are some places that commonly would be affected, but it has the potential to attack any part of the body.
Okay, and specifically tissue or even non-tissue as well?
Okay, if I go with the layman's definition of tissue, because, sometimes in medicine, I would say blood is a tissue as well, but another person wouldn't call that tissue. So it's blood, skin, joints, muscles, brain, nerves, basically everywhere. So I would say both tissue and non-tissue.
So I'm going to ask a dumb question now.
No, yeah.
No, it is a dumb question. I insist. So if lupus affects every part of the body,
Yes.
tissue, non-tissue, joints, muscles, blood, name it, why do we have the different kinds of autoimmune diseases you mentioned earlier on? Why are they not all just grouped under lupus?
Okay. Now, those other ones, like I mentioned, there are some that are organ specific. Things like if you have Graves' disease, that's autoimmune disease affecting the thyroid gland. You can have autoimmune hepatitis, autoimmune disease affecting the liver. Those ones are kind of more specific. And then also we have the ones affecting the muscles. That's the one called inflammatory myopathy. But lupus seems to be like the mother of them all, if I could put it that way, because it could affect all these other organs that have been affected by the single autoimmune disorders.
Yeah.
Okay, so that's what differentiates lupus from the other ones. And then also, those other ones also have like some specific things. Things like systemic sclerosis causes more of scarring of the internal organs and the skin. But lupus itself, what it causes is chronic inflammation and then damage of the organs. So lupus is different because, one, it is multi-systemic, it's not organ-specific, and then just like the other ones, common to all of them is the fact that they're all autoimmune, but lupus is more encompassing than other autoimmune disorders.
That takes us to the symptoms now.
Yes. Now, for the symptoms, because most of the symptoms caused by lupus would be caused by anything really. Let me give you an example. For the skin, you can have skin rashes, particularly on the parts that are exposed to sun. The rashes are called photosensitive rash because the sun makes it worse. So you can have a rash on your face called the butterfly rash. I wish we had pictures, but anybody can look that up, because it affects the bridge of the nose and then the cheeks. So it's almost spread like a butterfly. Then you have also joint pain and swelling with stiffness that is usually worse in the morning. Then you can also have ulcers, wounds, soreness, sores in the mouth, And then it can also affect the kidneys. And when it's affecting the kidneys, the symptom would be one, you could notice that your urine is a bit frothy. It almost look like somebody puts detergent in the loo before you use this foamy urine. And then sometimes it can cause swelling of different parts of the body, the legs, the face. And then also if you need recurrent blood transfusions because it's causing anemia. So these are some of the common symptoms. And then I will not also, then sometimes cough, difficulty in breathing when it's affecting the lungs. If you notice, it looks like anything could be lupus. So it's when so that's why to make a diagnosis of lupus, we don't use just one symptom. We need to have a constellation of these symptoms occurring at the same time or in an additive manner. Let's say somebody complains, I've been having recurrent fever, and then after a while, I noticed sores in my mouth, and then my joints are painful and swollen. I noticed that my face is getting puffy. So that would now bring a suspicion of lupus. So we have about 11 symptoms, 11 clinical signs. If we have 4 of that in an individual, it kind of picks our suspicion for lupus. And then we now go to the lab and do tests to confirm if this is lupus or not.
Okay, you've already dovetailed into my next question, which is good, by the way. But I'd like for us to explore it some more, which is diagnosis. Now, before we share this recording, I mentioned to you that from a very young age, I've really enjoyed watching medical dramas and TV shows, series. When I was really young, there was ER. Also, we have the likes of House MD, and one of my all-time favorites, by the way. And from the way you just smile, I think you liked House as well.
Who wouldn't like House?
Crazy fellow, but genius, no doubt. Now, what on the House MD especially, lupus came up a lot in a lot of the episodes. A lot of the patients who presented had that, but it usually seemed like it was a last resort. And once again, I'm the novice here. It seemed like when they were carrying out the investigations, there's a medical term for that. I don't quite remember right now. When you're trying to figure out what's wrong with the person, with the patient who's presented, but when they're checking this and checking that and checking this, and House has his team, and everybody's. It's almost like when there's nothing else to say.
Okay, then you
when we think that, okay, we've tried this, we failed, we tried that, we failed, we tried that, okay, so let's just go with lupus. Is that like the last resort sickness that we go to when we don't know what it is? Let's just blame it on lupus.
I've also had that a lot. I've had patients pushed to me, like when nobody seems to be able to figure out what is wrong. They just say, "Oh, Dr. Tralagba, take a look. Could this be something autoimmune?" And that's part of why I'm happy to be here. I don't want it to be a last resort, because by the time we wait and look for other things, no damage. The illness doesn't say, "Okay, I'll hold on a bit while they figure it out." There's ongoing damage. So that's the message for today. I said it's commoner in young females of reproductive age group. That will be between the ages of 18 to about 45. Then it's also good to mention that you can have it in kids as well. But this where it up. So if I have a young female who has been complaining of recurrent illnesses, says, "Oh, I'm always having fever," and then next thing, "Oh, I don't know why my blood is shorting." I'm using the usual term. They say, "My blood is shorting. Every time I have to be transfused, my joints hurt. I don't understand these rashes on my skin. My hair is falling. I don't know what's wrong." Most times they say, "No, it's from the village. No, what's happening?"
So the ever-present village people.
Yes. So usually when we have that in a young female, think lupus. Even if it's not lupus, it wouldn't hurt for it to be checked out. So we are saying that when you have a constellation of these symptoms, and then a young female of reproductive age, think lupus. Not to say that it can't affect males, but then with a ratio of about 9 to 12 is to 1. That's 9 to 12 females affected for every 1 man that is affected. It's common in this age group. But if you see these symptoms happening, let's think lupus. While we are evaluating for the other things that could cause it, let's also evaluate for lupus and not wait until it's like every other thing has failed before we now say, could it be lupus?
Okay, still with diagnosis. Now, you
Okay.
said that if we can identify 4 factors out of about, I think you said 11.
Yes, I'm going to talk about the 11.
Okay, so do you want to go over the whole 11?
Okay, yes, I can go over
Okay,
the
no,
whole 11.
let me ask the question
All
first,
right,
but then I can go over
okay.
the 11. So if we identify 4 symptoms out of 11, then we can safely say it's lupus. However, unlike other diseases like malaria or typhoid, you name it, is there a specific test that identifies, oh, that's lupus?
Yeah, I'll
Or
talk
do we
about
just
that.
say,
Okay,
okay,
no, no.
it's this, it's this,
Okay. Yeah, I
lupus?
get you. Okay.
Yeah.
So when I talk about 4 out of 11, this may be, okay, doctors, there's a part that the doctors have to play, and then there are parts that the individual and the people around the individual would have to play. So let me go over them. The first is serositis. Serositis is a medical term. It just refers to inflammation of the covering of the heart and the lungs. So the covering of the heart gets inflamed and the person starts to have fluid surrounding their heart. So that would come as chest pain that gets better when a person sits and leans forward. The covering of the lungs, if it's inflamed, the symptom would be pain that comes when you take deep breaths or when you cough. So if a person has that symptom, that's already one, that's serositis. The next is oral ulcers, sores in the mouth. Everybody has an occasional sore in the mouth, but when it's recurrent, that's also another symptom. The next is arthritis, which is inflammation of the joints. And usually in SLE in lupus is inflammation of multiple joints in a migratory way, in the sense that it's like it's moving from one joint to another. Joint pain, swelling, stiffness, particularly worse in the morning on waking up from sleep or during periods of inactivity. So that's 3 now. The next is skin rashes that are photosensitive. That's you go out in the sun and the parts of your body that are exposed to the sun, you get reddish rashes on those parts. Then the next will now be the blood disorders, where your red blood cells would be going down. The platelets, that's the cells that are responsible for clotting, they will be going down. The white blood cell count, the soldiers of the body, they will also be going down. So I think that should be about
It's like 5 or 6 now.
6, yes.
Okay.
Then the next is the kidneys. When it affects the kidneys, the symptom sometimes is asymptomatic, you wouldn't even know. But when it presents with symptoms, the patient can have passage of frothy urine, facial puffiness that is worse in the morning, or a reduction in the urine volume, or passage of coke-colored urine. Okay. Now the next will now be the brain, the nervous system affectation. You can have depression, anxiety. There's even an article, a published article from Nigeria, where stark madness, psychosis, was the first presentation of lupus in a patient. And then we now have the butterfly rash I talked about. Then also hair loss, patchy hair loss. I would describe it like where, when we use relaxers for the hair and you have bones from relaxer. So this is happening in the absence of any chemical inducing it. So you have patches of hair loss. Then this is about 9. Then the 10 and the 11 now are laboratory investigations. One is the anti-nuclear antibody that checks for the antibodies, the abnormal immune cells, okay? So, and then the other one is now another antibody called anti-double-stranded DNA. So when you talked about what specifically, so these antibody tests are the ones that are confirmatory. These symptoms can happen in anybody, but if you have these symptoms plus the positive antibody test, it clinches the diagnosis of lupus. So we have the confirmatory tests, like the antibody test, then coupled with the clinical features, which means even if I have antibody tests that are positive and there's no clinical feature to support it, I can't make a diagnosis of lupus.
And that was a lot to take in.
Oh, sorry.
No.
Okay.
I mean that in a positive way.
Okay.
So everything could be lupus.
No, not everything. Not everything. But lupus is like my teacher, he would always call it like is the hydra-headed dragon, like almost like Medusa, like with multiple presentations and everything. But that's why it's a science. We are able to put all these things together and then do the confirmatory test and say, oh, the bad guy here is lupus.
Okay. All right. So now we figured that the bad guy here is Medusa, lupus. We got Medusa in the building being the body here. So what do we do about it then? Is there what treatment is available for lupus? Can we reprogram those white blood immune cells to start functioning properly, or do we just treat the individual illnesses we've identified?
Okay. Now for the treatment, like I would usually tell the patients that I manage, it's not malaria. It's not malaria that after about 3 days of taking a lumefantrine combination, you say, oh, I'm good, I'm cured. Because the problem is in the genes, it's not something that can be cured, but it can be managed. And the management is not only symptomatic, like take care of this one, take care of that one. You can actually take care of the problem from the roots. Since the problem is immune cells attacking healthy tissues, it's only natural that the treatment will be immunosuppressives, drugs that would suppress the immune cells. Now, I know your face is already squeezing, like, is it good to suppress the immune cells?
Can the person have too much immunity?
Yeah, so it's not like too much immunity.
Okay.
It's too much immunity directed in the wrong way. So we are giving immunosuppressives that will suppress the immune system and stop the attack or reduce it to the barest minimum. But then it's a controlled suppression with a lot of monitoring because you're tweaking what should naturally help an individual. So while we are suppressing, we are not suppressing to the point that any infection that goes around in the air, the person can just catch that. So it's a controlled suppression with a lot of monitoring so that we are getting much more benefits than damage. I presume that at some point we may also talk about the newer therapies that we have now that are sort of more targeted so that in a bid to suppress the immune cells, you're not also suppressing the good ones that should help. So the treatment is immunosuppressives. And long-term immunosuppressives.
Long-term, can I say permanent?
So sometimes when I say permanent, it almost looks like, oh, wow, so I'm going to be on these medications for life. But what I usually say is that when a person living with lupus starts these medications, the initial time when there's a lot of inflammation, you may have to be on multiple drugs. But as you continue to get better, the number of pills the patient has to pop continues to get smaller and smaller until we arrive at a point where you're taking the least amount of drugs to keep you stable. So long-term, sometimes lifelong. But then I must mention that our target is for the disease to go into remission. That's our treatment target, remission, where it's not causing symptoms anymore for the patient. And sometimes this remission would have to be achieved with medications that would continue, even though at lower doses.
Does remission happen?
Of course it happens. So lupus is characterized by periods of flares and periods of remission. So with medications, I've been able to, rheumatologists across the country, we've been able to get a lot of people to live a normal and healthy life, go into remission. But then there are triggers. Somebody could have a stressful life event. There could be an infection and trigger a flare-up. So when there's a flare-up, we manage that and then get the person back into remission. So remission is very possible with the right treatment.
But even with remission, treatment has to continue still.
Treatment has to continue still, but the doses are usually adjusted downwards.
Is treatment expensive? I mean,
yeah.
We're trying to let people know, right?
Yes.
Okay.
Okay. So treatment is expensive, but then the cost of not getting the proper treatment is even more expensive. Now, unfortunately, in blacks, SLE tends to, like the kidneys, let me use like, So in blacks, we have a higher level of SLE affecting the kidneys. And it's common knowledge, the cost of dialysis or a renal transplant and how difficult that can be to get. So even though treatment is expensive, the consequences of not getting proper treatment is way more expensive than treatment. But that's not to take away from the fact that treatment is quite expensive.
All right. It is Canvas, the Niger-Delta Roundtable. For this episode, we're discussing when the immune system threatens immunity in commemoration of World Lupus Day. My guest is Dr. Tralagba. We'll go for a break. We'll return in a moment. The conversation will continue. Stay with us, please.
In the heart of our journey, where the sun touches the earth and the wind whispers through the trees, a new chapter unfolds. A chapter where energy illuminates more than just bulbs. It lights up minds. A chapter of unity, a coming together with a common goal to energize futures and illuminating lives. In classrooms, young dreams evolve, inspired by the promise of a brighter tomorrow fueled by available energy. Small businesses flourish, becoming seeds of prosperity. Energy that empowers and is catalyst for growth and change. The future is energy. So, let's light up the path to a sustainable future together. Energy for you, me, and the world at large. Energy for people and planet. We are Renaissance.
Welcome back. Still Canvas, the Niger-Delta Roundtable. I'm Dio. We're discussing when the immune system threatens immunity in commemoration of World Lupus Day, an autoimmune disease. My guest is Dr. Uchechukwu Tralagba. Doc, thank you. Welcome again.
Thank you, Dio.
Lupus is not a great thing. like any other disease, but from our conversation thus far, I think in the family of diseases, it's a really bad one.
No.
It's Medusa.
No, no. That's not the message I want to pass across.
Oh, okay.
What I would consider a bad disease, one that is difficult to diagnose.
Okay.
And then also one that has no treatment. Lupus, that's why we are making lupus visible.
Is lupus not difficult to diagnose?
It's just to be difficult to diagnose, but not anymore. Like just you already knew about lupus before I came here.
Because I watched House MD.
And then there's a lot of advocacy and social media campaign. People are talking about it. Even this podcast we're having now is to create awareness for it so that it's better recognized. And then we have medications that are effective for managing it. It's almost like saying hypertension, diabetes. Those are diseases that somebody has to be on medications for life. So not to say that lupus is not something serious, but then the first solution to a problem is identifying the problem. And then do we have effective treatment? We have that for lupus. So it's not all gloom and dark. Yes.
Okay. Do we have any recent major advancements in treatment and research to combat lupus?
Yes. We have, like in Nigeria, let me start from home. In Nigeria, recently a registry was set up for lupus in Nigeria called the Lurin Registry, where everybody that has lupus has been registered, their clinical symptoms, the laboratory findings. Okay, so when we have such a large database of lupus patients, so we are now with that registry, we are able to look at, this is like our own local data. Before now, all we knew about the disease was studies from outside. But now we have our own local registry where we are able to see the textbooks are saying that skin rashes are the commonest. But among our people, we are seeing that musculoskeletal issues are the commonest. The textbooks are saying that this medication works best, but we have looked at our own people because we are different from the whites. This is what works best for us. So that registry is still an ongoing thing. It's like a continuous thing. We'll keep registering people, and we hope that the data we get from the nationwide registry would help us to develop our own local treatment guidelines and then our own local diagnostic guidelines. And then moving globally, there are newer medications too. When I talked about immunosuppressives, the fact that they would suppress all immune cells, good, bad, all immune cells. But we now have targeted therapy called biologics. Now, these biologics are able to target the specific cells that are causing the problem or the specific chemicals called cytokines without affecting other cells, unlike the broad immunosuppressives. The commonest of the immunosuppressive is something that we all know too well, prednisolone, and it has a lot of side effects.
Sounds very expensive.
No. Prednisolone is cheap.
Oh, okay.
Okay, that's why, and it's quite effective in suppressing immunity. That's why when people get that, they feel better. A lot of people with autoimmune disorder start with that. But with science and research, we now have what we call the steroid replacing drugs that are just as effective as steroids without the burden of the side effects that you can have from steroids. So the most recent advancements would be the biologics therapy, and then all that are specific. And then also there's research for gene therapy, but that's still a research. It has not yet been approved. People are looking at how to modify the genes that are responsible for SLE and see if they can target it at the level of the gene. But then that's not yet mainstream. It hasn't been approved. It's still in research.
Now, how does lupus affect the overall quality of life of a patient?
Just like any chronic illness, it's a lot to take in, particularly at the point of diagnosis. There's a lot of anxiety, there's a lot of depression, and then sometimes by the time you look at the cost of treatment, it's quite burdensome. So initially, it affects the quality of life negatively. But then, after, we've noticed that when some of my patients that come regularly for their checkup, their follow-up, by the time they realize that it's not just me, there are a lot of other people that have this. There's a community of people that have this, and they are all doing quite well on medication. Sometimes I look out from my consulting room, and it's almost like some of the other patients are doing the job for me, and they're telling this person, oh no, when I came, I was worse than you. I was always sad. But see, I have a child now, I have a family, I'm doing well, it gets better, it's not always this way. So even though the quality of life is impaired, with a lot of support, both social and from the family, and then support from the physicians that attend to the patients, a lot of them seem to improve.
I'm going to go back to what could be considered an earlier part of our conversation, but I think it's important. And the question itself might seem to provide the answer, but I think it doesn't entirely. Also, from watching episodes of House, you find that sometimes when a patient presents with certain symptoms, the symptom is being treated because, for example, let's say arthritis, pains in a joint, or whatever other condition it is, the patient might seem to get better initially with medication and treatment, then suddenly get very worse. And then whilst they're investigating further, they happen lupus. Does it mean then that when a patient presents with certain symptoms that suggest a certain illness, even if we're treating that illness, if we don't treat lupus, the patient isn't going to get better?
Okay, if I understand well, if somebody comes with arthritis,
for example.
Now the thing is, if we're working with arthritis, arthritis is inflammation of the joints. just like any inflammation, it would respond to anti-inflammatory drugs, which means if I give the person steroids or any anti-inflammatory drug, really, it would help. But then that would mean that I've not solved the problem from the root. I've only managed the symptom. So because the problem is still there at the root, it's only a matter of time before that, like the pipe that I've just plugged, before it will burst open and turn into something bigger. So I think the take home here would be, even if you manage arthritis can also be an isolated thing and you manage it and it's fine. But if somebody comes with joint pain and swelling, I would now ask other questions. And it's almost like it's a research, it's an inquiry, a clerkship. Apart from this, your joints that hurts, is swollen and is painful, do you have any other symptoms? Sometimes it could be something they failed to look at properly. Are you having fever? Have you been feeling dizzy? Have you had to be transfused? Do you have rashes? So when I add that to the arthritis, I would now suspect that this is something bigger than just arthritis. So it's not like once I see arthritis, I start to manage lupus. I ask questions that could point to the fact that this may not just be an ordinary arthritis. If I ask all these questions and the answer is negative, and I do the blood tests and I don't have that, then I can focus and say, okay, I'm dealing with just arthritis and manage it as just that.
Do all doctors take that course of action, or only rheumatologists like yourself?
Okay. So all doctors, from our undergraduate days, we have lectures, rheumatology lectures. And then even as part of residency, we get to rotate through different units and departments in the hospital. So all doctors are trained to recognize lupus. But then the recognition is so that you'll be able to refer the patient appropriately to a rheumatologist for specialist management. So all doctors should be able to recognize lupus. It's part of what we are trained to do.
Are there misconceptions about lupus?
Yes, there are misconceptions about lupus, and bit by bit, we are gradually eroding all these misconceptions. Just, I think my trainer, Professor Adelowo, would always say that he was the person that started rheumatology training in Nigeria. He would always say that back then, that half of his patients would come and say, na spiritual attack, they are attacking me from home. A lot of them would have to have been to many spiritual homes, because nobody would understand why today it's like you're fine, you're doing well, by tomorrow you're down. There's multiple sickness, there's illnesses presenting in different ways. So these are some of the misconceptions. And then another one is that once you have the diagnosis, no matter the medication you take, you're just gradually going to keep getting worse. But a lot of people are seeing the light now.
It has to be village people. How is it explain using medication, we are getting worse? And then today it was hand. Tomorrow it has moved to neck. Next tomorrow it has moved to shoulder.
But when you're using your medication properly, you get better. Yes.
Okay. All right. How do patients manage symptoms and manage to maintain a healthy life, even when they're dealing with lupus? What do they have to do?
Okay. Gradually medicine is moving forward to involving patients in their own treatment. Back then medicine just used to be, sometimes you wouldn't even know what you're being treated for, and they just give you drugs and say, go take this and then come back. And that's just comply to what I'm saying. And we were not getting good results. So recently, there's been a shift towards adherence, where the doctor and the patient are both involved in the management of any disease. And we have better results with that approach. When you're actively involved, you feel a sense of control over your own life. So things like diet, the kind of things like eating whole food, try to avoid things that are coming out of a pack. Then also a lot of fruits and vegetables, And then another way that our patients get involved in their own treatment is sometimes we discuss about you're taking medications for life. How do I incorporate this into your lifestyle? What kind of job do you do? How can I help you so that you're able to take these drugs? Is it better for you to take in the morning or at night? And then support from the managing physician, support from family and friends, and then support from a community of other people that are living with the same disorder that you have. So these are some of the ways that patients are able to cope. Then we also have support from philanthropists, people that are able, and then the government, people that are able to help with finances for the medications and the treatments.
Speaking of support, what kinds of support, or what other kinds of support besides some of the ones you mentioned already?
Okay,
do
family,
the patients
friends. Sometimes we have the National Health Insurance Scheme where there's subsidized treatment made available to patients. They don't have to pay like the full price for medications and also for treatment. And then we also have support sometimes from pharmaceuticals, particularly maybe for some, we are not particularly resource poor, but you get what I mean, where these pharmaceuticals are able to give these medications at subsidized rates. And then we also have support from allied health professionals, not necessarily the doctors. I mean, the nurses that work with us. Sometimes we have psychologists that come in to also tackle the psychological aspects of the disorder. But then nothing trumps the support that comes from the patient's immediate family, friends, and then the community of people that live with the disorder.
Now, speaking of insurance, whether it's the National Health Insurance Scheme or other private insurance, the person has to be signed up or signed on to an insurance scheme to benefit from it.
Yes.
So what I'm trying to say in essence is being deliberate with health insurance is very important here.
Yes, it's important. And also, we are also doing a lot of advocacy and discussion with the government because for most autoimmune disorders, for health insurance, it doesn't really cover a lot of the medications that they require for now. But there's a lot of discussion going on at the moment for this to be corrected. And then for the private insurance companies too, most times you have to be on the highest level of insurance to be able to cover rheumatological conditions. But I believe that with all the advocacy that is going on, that the story would change in the recent future.
For a person who's been diagnosed with lupus, and not just that person, because you mentioned a while ago that they require support systems, first and foremost from those closest to them, those who are around them. So what advice do you have for that patient who's been diagnosed with lupus and those who are close to them as well?
Okay, I would usually say that the first solution to a problem is recognizing the problem. The fact that we have been able to make a diagnosis means that we are 50% there already. Now we know what we are dealing with. And then I also tell them that it's not always going to be like this. At the time that you're starting treatment, because there's a lot of inflammation going on, we may need to give a lot of medications, monitor you closely. But by the time you go into remission, the hospital visits and become wider apart. The number of medications you have to take will continue to reduce. So the fact that we have a diagnosis is already a step in the right direction. And then that with medications, we'll be able to get you into remission. And also another nice thing about the medications is that there are a lot, we have the first line, the second line, such that if we give you this first set of drugs and we are not yet at target, we have the second line drugs to fall back on. If we don't get to target with the second line drugs, we have the third line drugs, you understand? So we have a wide variety of options to go with. And then even though the medications are quite expensive, so what we do is sometimes, because we have multiple options, we can go with what suits a person's pocket and then work with that. And then we also liaise with some pharmaceuticals that are able to provide these medications at a subsidized rate. So I usually say, I know money can be a problem, but we are here to support you and look for avenues that you can be able, that would help you to support your treatment. So usually at diagnosis, it's usually a lot of back and forth. They have access to my email where they are able to tell me at random points in the day, this is how I'm feeling, this is what's happening. Then we also work with an adolescent and child health counselor, because I told you it starts usually from about age of 18, then goes on reproductive age, who is able to offer psychological support. So even though those first few days, few months are quite scary and hectic, but by the time they start to feel better, they now get to understand that it's bad, but it's not insurmountable. Yes.
How about those close to them?
Okay, those close to them. So I usually advise that everybody should have a treatment partner or someone that supports you. So most of them don't usually come to the clinic alone. They come with someone. Sometimes we also, not just me, rheumatologists across the country, it's almost like you're managing the entire family. So in my consulting room, sometimes there are like about 3 chairs. It's almost like a conference meeting. The patient is sitting, the partner, the parents, the siblings, everybody sits with the consent of the patient, of course, and they all get to hear and ask their questions. So getting them involved and also interacting with them helps them to understand better what the patient is dealing with and what ways they will be able to support effectively.
So what advice do you have for them right now?
The family.
Yeah, who are watching. Those close to, or listening, those close to a person who's been diagnosed.
With lupus. Okay, offer support. Most times in Nigeria, most times people think support is just money. Or since I don't have money, there's nothing I can do. Money is very important, very, very important. So support financially if you can. And then also is try to understand what this person is going through. Some of these people, employers, understand why it's like on Monday you were sick, on Tuesday you were sick, what's wrong? And so support, understand that this is a chronic illness that can flare up at any time. And then also understand that the lupus itself messes with a person's brain. All that depression and anxiety, it's not intentional. They're not trying to suffer you.
He knows what he's doing.
Yeah?
He knows what she's doing. She's just trying to suffer.
Yes. Try to be empathetic. Try listen. Be the shoulder that they can lean on. Be that person that they can talk to about how they are feeling, and then also support them to be adherent with their medications. Things like, have you had your drugs today? And ask for ways that you can be of help. Don't impose the kind of help you want to give. It's a simple, how can I help? How can I come in? And then they'll be able to express exactly what kind of support that they need. Lupus patients need to be heard. Be that ear, yeah.
Thank you.
Thank you.
My last
much.
question, I think, one of the most important questions I will ask you for this recording, and then we'll wrap it up.
Okay.
What do you think of the character House from House MD?
Dr. House.
Yes.
I think he's very intelligent, and then I think he could brush up his emotional intelligence a bit. Sometimes he could come off as brash. Sometimes, I don't know, it's almost like he's a bit conceited with all that intelligence. Sometimes he acts a bit dismissive. I don't think in terms of his intelligence, he's the model doctor. But sometimes in his doctor-patient relationship, he could work on that a little bit.
So that combination, would you say he's a good doctor, considering all of the factors?
Yeah, he's a good doctor. Just like everybody can always get improved on. So he's a good doctor, but he could improve on that other part.
Are genius doctors always like that?
No.
Okay.
No.
Just him.
No. It's fiction.
But it could be real, I guess.
Okay. No,
You don't
genius
think so?
doctors aren't always like that.
Okay.
Yes.
All right, great. Thank you
Can
very
I
much.
say something,
Yeah, go ahead,
please?
please.
Yes. Because it's World Lupus Day and the theme is Let's Make Lupus Visible Together. Thank you for the opportunity to talk to a lot of Nigerians. And then what I would like to say is, if a person has recurrent fever, joint pain that is worse in the morning with stiffness and swelling, skin rashes, hair loss, sores in the mouth, passing foamy urine, having to need multiple blood transfusions, the face is getting puffy, the legs are getting swollen, and it's almost like this person has been sick for a long time. Sometimes they say, I was treated for malaria and it was malaria and a little typhoid. It may not be malaria, it may not be typhoid, it could actually be lupus. So present to the hospital and get properly checked for lupus. That's my take-home message. Thank you
again, Doc. And that's a wrap for this episode of Canvas, the Niger-Delta Roundtable, brought to you by Renaissance. In commemoration of World Lupus Day, May 10, we've discussed when the immune system threatens immunity. I've had a fascinating conversation with my guest, a consultant rheumatologist, Dr. Tralagba. Thank you so much for your time.
Thank you, Dayo. It was a pleasure being here. Thank you.
And remember, if you're having all of these symptoms, 4 out of about 11 that the good doc mentioned just a while ago, even though it's paining from the neck and it went to the head and went to the shoulder, it's not your village people. It just could be lupus. Present at a hospital. Bye for now.